This is one of our initial pilot patients on TPN. We thought for sure this patient was taking their TPN every day. And essentially, if you look, another 79-year-old woman had short bowel syndrome complicated by Crohn's. And at this point, she was receiving weekly labs. And, at some point, you got to get to the point of where you have homeostasis and you can actually start moving the labs back. And, if you think about anyone who's providing care to these TPN populations, right, nurses got to go in, draw the labs, got to drop them off. Then from our end, we got to find the labs, trend them, get a new script. And this is really a concept in that if patients would follow care, operationally, things get a lot easier for us, right? It's a lot easier to refill a TPN than basically work with the physician, change the macros or the electrolytes, and then basically get it to the clean room and compound it. So operationally, we really worked with this patient and said, hey, you would take days off, but then she would double infuse. So, a 79-year-old woman taking 6 liters of fluid, it's probably not the best thing for, essentially her cardiopulmonary systems. If you look at the lower scales there, the first one is basically a typical TPN. When you see this nice taper up 1 hour, then you have your basal and you taper down. And then in addition, you can see the pressures associated with this. And this was another area that we wanted to work with Eitan because, believe it or not, we had some patients that we knew, especially in the eating disorder diagnoses, that they were actually just disconnecting and either watering their plants with it or basically down the sink. So, with this patient, we're enjoying, once a month labs and, operational efficiencies associated with that. This particular patient, if you look at LB, she's a 40-year-old woman. She has multiple comorbidities. And the scenario is that she has an ostomy and she kept on bouncing in and out of the hospital, right? We put her on the pump to understand what the heck is going on, right? Because her ostomy wasn't healing or what have you. So when she did take the TPN, she would either take some of it, maybe all of it, but more importantly, she was disconnecting midstream. So if you see where, she had tapered up successfully, but all those troughs associated with that, and then when you compare that with the pressure, she was actually disconnecting. And one of the worst things that, we're seeing through this pilot is that when patients disconnect and then reconnect, they're almost ultimately seeding their lines with an, infection. So for any of the money people in here, when that patient goes back into the hospital, we've just lost a week's worth or maybe 10 days worth of TPN revenue that would have been, obviously something that the payers don't want to pay for. Obviously, we didn't want to lose. And really the hospitals don't want to see it because, number one, it's affecting their scores. But in addition, many of the hospitals just don't have the bed space or the employees to actually, care for these folks.